Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator, and we'll take you through another exciting case. The case feature today is going to heavily emphasize on the teaching points of a retrograde approach towards doing a chronic total occlusion. We will also specifically go into the details of the modified Kinney retrograde technique and demonstrate to you pragmatic ways how retrograde CTO can be done more effectively, more efficiently, and hopefully with less fluoro times. There is also going to be another exciting announcement which I'll allow Dr. Sharma to announce for you. This is in response to the overwhelming request we've had globally from our audience to augment our program, and it is also a new educational initiative which is consistent with the educational mission of the American College of Cardiology. So with that introduction, let me take you to the cardiac catheterization laboratory where Dr. Kinney and Dr. Sharma are standing by. Anu, good morning. Samin.
Yes, good morning and welcome.
So what is this new thing which is going to happen?
Well, actually, as you mentioned, that big demand to be globally, and with the mission of college, the demand to have a Spanish translation because of wide range of audience. We are going to start very shortly the simultaneous Spanish translation, and hopefully with the goal that reach further to our various countries, and we'll have a more input and the live participation of our audience from these countries. So Spanish translation will start very shortly.
I am sure the audience is going to be delighted because when we pull together, this has been the single largest request over the last several years.
Absolutely agreed, yes. And as you saw that we started with Chinese, and now we go to Spanish, and of course get more demand, maybe go to Japanese. We'll see.
Excellent, and particularly I think this is going to be excellent news for the numerous cardiologists, the thousands of us, of them who follow us from Central and South America. In particular, I am referring also to the cardiologist from Mexico.
Great. Now, with that note, with my team here, Anu on the left side, I have two fellows, Dr. Lahani and Varghese. We'll start this case. As mentioned, that there's a lot of work in the literature and buzz about retrograde. How do you retrograde? When to do retrograde? So the goal today will be, one, show the case, and of course before the didactic discussion of a case which we want to do recanalization by the retrograde approach. So we start, let me just get to the case first, if we can get the slides, with our disclosures and sponsors. This is a 62-year-old male who presented back in June with the new onset of crescendo angina and infralateral ischemia. Has 3-vessel disease, as shown here, 60% proximal LAD, 80% circ, and 100% distal RCA. Normal LV has a syntax score of 22 because of diabetic. Remember in the freedom trial, 3-vessel, irrespective of the syntax score, there was benefit of CABG. So this patient was referred to CABG but declined and had a PCI using resolute integrity of Zetrolimus 3.530 into the distal circumflex. Patient continues to have class 2 angina on maximum medical therapy. He has been on atenolol, amlodipine, aspirin, prasugrel, metformin, glimepiride, and omeprazole, and he could not tolerate the long-acting nitrates. And Anu will show the angiogram now.
So if you see, this is a LV function, anterolateral infrobase. Actually only the postrobase is the one which is hypo, overall just minimal LV dysfunction, and this is where we have is the RCA is a distal RCA, which is a total occlusion, and is a bridge collateral. There's multiple bridge collaterals because in some view it looks like there is an antegrade line, which is not true antegrade line. It's a multiple bridge collaterals, and a long lesion actually starts at the prox area, but moderate diffuse disease leading to total occlusion, and then you have distal RCA disease just at the bifurcation at the crux. This is on the left system, non-obstructive LAD, but the circ stent looks okay. We took just a cranial picture to see how the collaterals look like from the LAD to RCA, there is one large septal which goes and has a connection to the PDA, but very important is multiple septals. You can see that there is a connection which we will go over how to actually look for septal connections when we want to do retrograde.
I mean, it's a mega right coronary artery, we say. Once you're seeing this by retrograde filling, it's a 3+ millimeter vessel and seems to be a favorable channel for retrograde. The question is, always question will come, and we'll discuss during, if you go to the previous view, why not antegrade in this particular case? What deters you from going through the antegrade?
Same thing that we mentioned here is, one, the multiple bridge collaterals. I would not say so much about the length is still okay, but if you see there, at certain point, if I just stop it, if you see, at least 3 bridge collaterals we can see, which are giving us a false impression that there is a good antegrade channel. It is a bridge collateral. So, this is a case where you would like to, even if you try your antegrade channel, likely you got to be prepared to go retrograde.
Okay. Now, with that note, we go with the appropriateness. This case happens to be the U, because one vessel CTO on maximum medical therapy, and of course, patient has a positive ischemia. Now, 2 points I try to keep today very brief. Reason is we want to show the whole technique right from the beginning to end, and just brief overview of the CTO lesion success of the current era and the retrograde recanalization approach. The first current status, we all know that CTO is the problem, that right from the Barry to the syntax, majority of the patients who go for surgery are because they are CTOs. And success rate has increased, but clearly now 60 to 85%. More importantly, this is very nice Canadian multi-center registry published in JACC that although we see CTO is in almost 12 to 15% of cases, but approach that which center is more aggressive to going after CTOs versus other. This is data from Canadian multi-center registry, and you can see that in the CTOs you can have a 3 tertile, that going 1% versus almost going the 20% for the CTO. So clearly there is a big comfort level or experience level, and that is where the dedicated CTO centers like Sinai and others, a few of them in this tri-state area are performing these cases. So basically we offer our intervention at present of the 5,000 coronary intervention, CTO will make of about 10% the cases are CTO. The incidence of CTO is probably double or 15-16%, but actually the PCI of the CTO makes around 9 to 10% at Mount Sinai. Now there is a lot written about the favorable and unfavorable anatomy with the stump, total occlusion site, branch and collaterals, bridge, but clearly in the current era I would say the severe calcification, because many of these adverse unfavorable morphology can be taken care by the retrograde approach, but calcification, and it is supported by the multivariate analysis of the TOAST GISI, which is about the CTO procedural success, that severe calcification has a very high hazard ratio compared to others. Now, we also know that if you are successful, your complications go down. You have lower death rate, lower MI, lower perforations and tamponade, and of course, our successful cases have higher of these complications. So clearly, that once you attempt the CTO, success is the key. Once you increase the success, and this is what has gone over the years now, that this is the last data of about 80% success rate and constantly declining complication rate to 0.5% from the CTO registry. And we also know, as I mentioned, that success versus failure, that successful will decrease the mortality, decrease MI, subsequent cabbage and residual angina. And this is of the various data presented, this is the latest publication, that chronic CTO of more than 3 months, that successful is associated with lower mortality at follow-up compared to unsuccessful. So therefore, you can say it's not a randomized, these are the randomized data, but if you take the registry, successful CTO will have a lower mortality, lower cabbage, lower angina, and so. Now this goes back to that our residual syntax score. We routinely treat lesions, which we can do, but we many times leave the CTOs. And this is actually data from our syntax trial. The residual syntax score of less than 2, 3 to 8, or more than 8 is associated with gradient in terms of the MACE, death, MI, and the TVR. So clearly it makes sense that you try to do a complete revascularization as possible, because complete versus incomplete, many data have shown that complete revascularization associated with a lower event rate at follow-up. Now, also for the CTO, actually, that we have more device cost. This paper clearly puts together the CTO, the direct and procedural cost is higher for the CTO. And fortunately for us and the hospitals, at present, there is a separate comorbidity, which we call, it's a major MCC. Major comorbid condition, CTO. If you are attempting CTO, there is a differential higher payment to the institution, largely because of the higher device costs which have been shown. The second, very simple, is the retrograde recanalization approach. Basically what we are looking at into these channels, whether from the septals going into the RCA or from the PDA, or the PDA septals going into the LAD. Those are the two commonly done vessels done with the retrograde recanalization, and reserved, as I mentioned, for the LAD or RCA CTO by the collaterals. Avoid epicardial, those Kugli collaterals, very important. And the 4 techniques of the retrograde: direct retrograde crossing, kissing wire, then control antegrade and retrograde subintimal tracking, which we call CART, and the reverse CART. And these are the examples very nicely with a review article published from our Japanese colleague in JACC a few years ago. The kissing wire, the retrograde wire, the CART and reverse CART, basically using all our available technique in order to get into the subintimal space if you cannot easily get retrogradely into by the wire technique. Now, where are we in terms of retrograde PCI? This is the increased use of retrograde approach with the latest CTO registry data showing that almost 30% of the PCI are being done retrograde. Now, what it doesn't say that whether it is done as a first attempt or third attempt, but yes, the retrograde PCI really is coming, which is into the way, and that is increasing the overall procedural and technical success rate, and of course complication continues to be very low. These are the various trials of the retrograde CTO series, which talks about the technical success, what type of the septals they use and techniques we use, and of course the contrast use and fluoroscopy. And therefore we will put our together the data at Sinai, that where do we fit in this 6 studies Sinai data of the retrograde in terms of the time for the future. Now this is an important one, and I'll ask Vannu to comment on it. That is the 5 steps which we are going to show today. One is the procedure involves 5 key steps, because the retrograde has been accepted, that you wire the collateral from the donor artery into the distal bed of the recipient artery, usually with the use of a hydrophilic jacketed guide wire. Which wire in terms of is the preference?
Yeah, a couple of things before we go to that would be selection of the guide. We just want to make sure that we use 6 French guide and both long sheath. Mark guides which have a soft tip, so we know when we are doing intervention, especially you'll see it later on when if we are crossed and we have to get our corsair across, there is suction of the guide into the left main or into the RCA. So the guide selection is very important. We always go with the MAC and 6 French. Other thing is anticoagulation. We have always routinely used Angiomax as our anticoagulation, and antiplatelet therapy preferably has to be Plavix. Avoid the newer dual antiplatelet therapy, since we are going to microchannels and all that. They're more likely chance of perforation of the septals. Having these key points, if you go here, the septal, if you can show the angiogram at this time, if the main septal, if you see, there's one septal which has a good connection into the PDA. But that's the first major septal, and that's the first branch that goes directly into the PDA, but the second branch actually then bifurcates, and even we see connection of that septal. So we have 3 septals that we can see angiographically. So how would you start here?
Yep. Yeah.
You can see that?
Yeah. Although you would not be able to see. Now, the second is the delivery of over-the-wire microcatheter, especially Corsair channel dilator, to allow an exchange of a CTO-specific guide wire. That's you agree with that?
Yeah.
That's a startup with a Corsair really has helped to increase the success of the CTOs because go through the channel. Then third point is crossing the total occlusion with a CTO guide wire and dilating the CTO with a retrograde small balloon, 1.2 to 1.5, 8 to 10 millimeter size. Now question comes is, what should be the CTO guide wire?
So
If you cannot get through the your usual floppy wires.
to cross the septals, I would give 3 wire choices. They usually are the glide coated floppy tipped wire. So you have a regular fielder which has a polymer coating which has a tip load of like a 3.7. But what you need is fielder FC. Why it's FC? It's everything like fielder. It's not tapered, polymer coated, hydrophilic is a polymer and then there's hydrophilic coating, but the tip load is about 1.7 and you need a soft tip to go through these septals. If though these two are not available, you can still use Whisper. Now they have a newer one which is called the Scion. It is not polymer coated. It is tip has coils, but it has a hydrophilic coating. It was specially designed just to go through these small channels. But if you have these 3 wires, which is regular fielder, fielder FC, or your Whisper, we should be able to get through the septals. Those are the wires to get through the septal. Once you've gone through the septal, then your goal is to get your Corsair, and you have to make sure you have the right Corsair because they come in various length. You need the 150 Corsair, not the 130 or the 135 Corsair. You go through the septal, and once you are at the CTO level, you still use the same wire which has the soft tip to see you can go through the CTO. If not, then you try your other CTO wires. Usually go lower, which is Miracle 3 or something that you'll be able to go through that. Very rarely you need to go to the higher level CTO wires.
So therefore, knowing that the retrograde cap is less fibrotic, so usually these floppy wires of the fielder will work. If not, once you have brought the Corsair at the site of the CTO, retrogradely you can escalate the wire to a Miracle or a Confianza and just to cross it. And once you have crossed, and that goes to the 4th point, if you go back to our slide, that then once you are dilated, you have gone back and you are dilated with a small balloon, then place an anti-grade guide wire into the distal bed. Don't get too carried away that now we have to do everything on the retrograde wire. No. As soon as you open the space, advance your anti-grade wire and make the procedure simple. Now, many times you may not be able to go through the anti-grade wire because of tremendous dissection. In those cases, then you rarely exteriorize the long retrograde wire, which is the Viper wire, 360 centimeter of CSI, to advance the anti-grade monorail or over the wire small balloon. But that is required very rarely, maybe what, 10-15% of cases?
I would say half and half.
It's about half of them. But key is that you try to look into going anti-grade after you have done the retrograde opening of that total occlusion. And then of course the stent has to be placed over the anti-grade guide wire.
Yeah.
Very important. The stent has to go on the anti-grade guide wire. So when to do retrograde technique, and that's the important issue. I would say, because it requires extra skills, the retrograde technique should be done once somebody has accomplished a good number of CTO anti-grade technique cases. Whether this number should be 50 or should be 200, it's a matter of debate, but in my opinion, I would say 200 CTO cases with the anti-grade technique, and then you get to the retrograde. Then dedicated setup, equipment, and ability to handle complication, and some of the complications are little notorious. That is the spasm of these septals. They go in tremendous spasm. There have been a case report that you have to put patient under general anesthesia to relieve the spasm, and of course the intramural hematoma by rupture of the septal, so need to be ready to take care of those. Usually after failed antigrade, once or twice approach. Clearly retrograde technique should be except in a rare case that as the strategy once you fail the antigrade once or twice. And the lastly is the ostial stump occlusion. Probably there you can do a retrograde directly. Reason is you don't know how to go antigrade, may cause a dissection at the aortic valve wall. Therefore ostial stump occlusion will be a reasonable way to start at the retrograde. And you agree with that?
Samin,
Yeah.
there are often more than one operators, experienced operators involved. When you mention 200 CTOs, you're talking about as an institution or as an operator?
No, as an operator, I think this has to be the operator skills, because it should be a dedicated operator who is doing these cases. So it has to be very, I would say it should be the individual case experience before you start embarking on the retrograde technique. Although with this nowadays, the procedure being made simple, that number probably can go down to, I would say, safely to 50. But don't start your career with the retrograde approach first. Do a good antegrade, and of course, the antegrade will always have a less dissection, less stent use, better results. And if we fail, then only you go. So that I would say in this day and age, maybe we can cut down this number to 50.
Excellent. Samin, can you go back to the slide of the 5 points?
Yes.
Now, one of the things that absolutely compulsively eliminates is any reference to any re-entry. That's correct?
Right. I mean, the point is, the re-entry may require, particularly when you have a antegrade, card technique, that you could not get retrograde, so that what you did is you created a subintimal space retrogradely, and then antegrade you come in. The more what has been shown in the antegrade re-entry, which is has been shown by various latest our CTO registry data, that once you have a re-entry and long subintimal dissection, they are associated with very high restenosis, as well as the patient present back with a total occlusion. So we try to avoid that long extensive dissection and re-entry technique of the star variety. Then lastly, just I put it so that we are ready for it, the fundamental wire technique and the current strategy for CTO, procedural steps: 1, contralateral dual injection, CTO PCI, tried antegrade, approach 1 or twice, single wire, parallel wire, and then if fails, then you go to retrograde. Could be a wire, retrograde wire, the kissing wire, the cart or reverse cart. And some people do believe in IVAS, which we have not used it. And of course, idea is there you go and the success, and then only you get to the re-entry, as you mentioned. So with that note, Anu, it's all yours. You tell us what's your next step now.
I think 3 challenges that we normally face here in a CTO where we are going to go, start with the retrograde is: 1, find the right septal and go through the septal. Second, get your, even though, the one here angiographically we can see septals. There are many cases where you have tried antegrade, failed antegrade, now let's try retrograde. You don't see a good septal channel. It's still worth to go through the septals, because many times angiographically you may not see it, but wire will go through it. And the challenge there is, even though the wire goes, the channel dilator, which is Corsair, may not make a turn. Since your septals are curlicue, so that's the second challenge we face, that the Corsair may not make the turn into the RCA, and after that another challenge is crossing the CTO retrograde. Once that is done, the next challenge is, if you want to try to get your retrograde wire into your guide, which is retrogradely into the right coronary artery or into the left main, that is another challenge. But I think as we go by, I will go step by step how you cross the challenge as we face.
Okay.
So right now,
the floor.
Yeah,
we are on this view.
I have the regular fielder, Corsair. We have a Mark VL guide that is sitting. Our ACT is about 290 on Angiomax.
And I think this will be a very interesting observation, because a lot of people still very much concerned about the Angiomax, knowing that it's not a reversible anticoagulation. But I can tell you, our experience is totally different. And we have no hesitation going with the Angiomax, knowing that data have shown our own, that even if you have a little perforation, it's a self-contained compared to if you use the heparin, and it's less catastrophic. Now it looks like the guide may be a little too big here, but let's make a little counterclock turn. This is 3.5 VL. Okay, so we may look for a 3 or make a better curve on the 5. Yeah.
Samin, a very interesting first question has come. Did the patient decline surgery, or did he prefer PCI?
Well, I mean, this is a very good question. What we do is our protocol for high syntax score or freedom trial type of patient with 3 vessel and multi-vessel, diabetic patients, that we go with, we ask those cases, we stop, take the patient out, get the surgeon discussion, and after discussion, it's not uncommon, half of this patient, despite our recommendation, the patient will decline, say that, you know what, doc, I want to try PCI, and so therefore it's not that the surgeons have declined. Basically, as you know, which we have shown in the past, that our guidelines are the class 1, the heart team discussion. Now after that, patient is still, we have to decide or do what patient wants. So that after discussion with giving patient appropriate feedback that what is best based on the data, patient may still decide what to do. And this is exactly happened in this particular case. Now, which wire it is? Say what
This
wire?
is a regular fielder I have.
It's a regular fielder now, because many people actually will start with a fielder FC.
Some die.
Yeah.
I think I'm not in that that one that has a connection. Yeah.
Yep. Now, PVCs are very common when you advance these wires. Should we be worried about?
Probably not, as long as you know.
Yeah. Now let's see here.
No,
that
we are
you
in
in the
that-
main channel or distally?
So there, when you reach the distal septal, I think good. We went through.
Good.
So this is the one that I would say the technique, modified technique, which I
Take a
have.
Cine.
Okay, go.
Yeah.
I do, in the sense that normally what has been shown and taught is you find the septal in the angiogram. Then what you do is to get your corsair all the way to the septal, take out your wire, you take a picture, and then make a decision which of the septal connection is a straight connection to the the retrograde the other vessel, and then you then you go change the wire direction, the tip, and then you actually try to rewire it and keep going. But as I showed you, go with your best wire, which is a fielder. Try to cross the septal. Many times we are able to go through it. If not, then you change to your fielder FC.
Okay. So now you are advancing your corsair.
Yeah.
So, I mean, Corsair, of all the equipment you use for a CTO, that is your absolute default.
Well, I would say that truly, I mean, this is a tremendous, this retrograde success. If you ask me, the success of retrograde recanalization has increased by 20-25% point after using the Corsair.
Yeah.
Because Corsair, see, going
So
through this
now,
area
this is-
otherwise would have been so difficult.
Okay, the important point is same. We knew the septal all the way would be okay. The corsair will make a turn. Where you normally face trouble is when the distal part of the septal, where the septals are really thin. That's where you need the help of the corsair, where you may have to counterclock to make the channel dilator to get into the PDA. Many times what happens is that even with the corsair, you may not be able to dilate that particular part of the septal, and that is where you need balloon dilation of the septal, where what means you take out the corsair. Same, you can use your wire anchor technique, take a 2.5 balloon, dilate the balloon in the guide, take out the corsair, go with the smallest balloon, which is usually a 1.5 or a 1.25 balloon, which any balloon that is available, go there, dilate the septal. You have to be very careful not to go more than 3 or 4 atmospheres, and that is one thing that has been shown, that once you're dilating, where you may develop septal rupture or hematoma, which we have seen, and then you can get your corsair back and dilate the channel, and you'll be able to get into the PDA.
Okay.
Or vice versa.
Now, at what point you'll like to see the antegrade, or you're okay now?
Let's see. See, I'm having trouble in getting the.
Go to low mag.
Yeah.
So have to have which idea? Good.
No,
So now you need to go to other views to see exactly which channel we are going to go
Same.
for.
I'm having trouble
You
with
want to hold the
advancing
guide? Go other side. Hold the guide slightly. No, this side. Yeah. Because clearly there you'll require, and it's a corkscrew, and you'll require the holding the guide, because guide will come out because even if you are in the true lumen, because of the total resistance which have been imparted by this system. Good. I think this will be the good one. You want to take just picture? Get a picture here. Okay, you will inject. Good. We're doing both injections?
You don't need both, I guess.
Yeah, just to say. Yeah. Good. Now still is that area, so now you need to see exactly, very nicely it has gone back up to little past, I would say, the CTO.
Yeah.
Now you want to go to RAO view, or which view would now?
No, I will see if I can get the wire into the...
You may need a little support now.
Yeah, and this is where, now some dye in the RCA,
Antigrade.
anti-grade.
Yeah.
Is this the point you'll aim for anti-grade wire, or continue to work? Not yet.
I
Okay.
need some support from the Corsair if I can get the Corsair in. But this is actually what you face. But same, be gentle.
And particularly the corkscrew, you can just the corkscrew, their Corsair, up to 15, 16 times in each direction. And then, of course, it will get too much turn, you do counterclock. Now, once you do a counter turn, that guide will suck in. So make sure the guide is out in that situation.
Sir, take a deep breath.
Completely eliminated the tornus.
Yeah,
Yeah,
we
yeah.
actually do not carry tornus in our cath lab, because we did not find any use
dye?
in the sense beyond beyond Corsair. Reason is the Corsair with a torpedo shape pointed end is very, very useful in these cases.
You see the true use of IVUS in CTOs. Is there an over-reliance because that kind of takes you down the re-entry pathway? Or
Yeah, exactly. I think the IVUS, as I showed part of the slide, the more important IVUS is for the re-entry point of view.
RCA
Integrate?
injection.
Yeah, the re-entry point of view. And I still believe that less role of the IVUS in the CTO, and I'm sure even with the Japanese literature, we actually having a less impact and less outcome, or that IVUS does not impact that much in terms of your CTO recanalization.
Also, what very important is just by the heartbeat. See, I'm not pushing too much. With the heartbeat, I just have a little pressure at this, and every time with the heartbeat, I think the Corsair just keeps moving. You don't have to use, if you see that,
Yeah.
every time with the heartbeat,
Yep.
it keeps moving
It will keep
forward.
moving further.
And same, pay attention to the guide at the left main all the time. I'm trying to see some dye in the RCA whether
Integrate.
think, yeah,
Yeah.
we not. I think it has taken one of the bridge that is not what wire you want to change.
any situations you are getting a cardiac MRI to demonstrate viability sometimes, or
Oh yeah,
not at all?
viability, of course. I mean, in any case, you try and do a CTO recanalization, you better sure that it's a viable and ischemic, both. But a lot of people actually use the CT angio to look into the course of the vessel, retrograde vessel. And secondly, that if it's a very large plaque burden, which has been associated with distal embolization, so that don't avoid CTO. Actually, Japanese have
Give the miracle.
that have written a paper
Six.
on this issue, that if there is a too much, you want to make curve first?
Yeah, yeah.
That
No,
if
take this. Okay, hold it.
yeah, that if there is a too much, the very large plaque burden, that in those cases, based on the CTO, do not do a recanalization of the CTO, particularly retrograde, because it will be associated with tremendous myocardial infarction, slow flow, and so on. So therefore, that is incorporated. We actually, we are not use that routinely, but this is something which is to keep in mind, particularly if you don't see the course of your vessel.
1/3 angiomax.
Talking about publications emanating from Japan, there is a more controversial one coming up to be published soon. The Kyoto Credo trial, which is demonstrating no survival benefit.
Absolutely, that was presented recently in EuroPCR, that they are the leader in this field, and they showed that their trial showed no difference in improvement in mortality even
RCA.
after successful recanalization. But I think that even standalone, no trial ever showed that it's a better in terms of mortality point of view. It's only when you make a meta-analysis of the multiple trials. So you have a little trend, but once you have a large number of 5,000-6,000 cases, then you'll make sense in terms of decreasing the mortality after the success. And knowing in the trial that the Japanese trial, the success rate is already 86-88%. So clearly that standalone you will not see. But many the randomized, as I said, registries actually have shown to have a benefit once you combine them, not as an isolated.
So 200 cases for a decently experienced interventional cardiologist to start doing retrograde CTO.
Yeah.
How many cases do you need to do a transradial CTO?
Well, I mean, if we go by the Ravel criteria, they actually wanted to make sure that the people who are doing, they had done 200 diagnostic radial and 50 the radial TRI, transradial intervention, before they could be the operator for the Ravel trial. So that number is about the same even there. The 50 interventions were minimum. And the center, actually, there was also minimum center was 200 radial, 200 or 400. That I exactly do not remember. That number of radials required to be the site for the Ravel center.
Confianza 9. What has happened? I think no, not whisper. The question is what has. See, it took one of the.
Why don't you try the integrate right now? Get a one wire, one small balloon integrate. Or
just let me do one
okay.
wire exchange here.
So Confianza is your next choice, Anu?
No, we try. This is Miracle 6. I'm trying to see. Since it's one of the bridge collateral we are in, we are not intimal. I mean, we are still subintimal. We are not in the lumen yet. So I'm trying to see if I can get into the lumen, because we have lifted we have created a subintimal channel there for a short.
To our viewers, please send your questions to info@ccclivecases.org.
Die the RCA.
give me the whisper wire.
Whisper? Why?
No, I'm for the integrate we are talking.
Some die now RCA.
Would that be normally your first choice, or because of the tortuosity?
Which one?
The whisper antigrade?
It's
a little bit tortuous. So, Samin, another interesting question. Has your increased CTO volume started impacting the business for the surgeons?
Well, actually, the business for the surgeons is increasing, and we track them. It largely because of our incorporation, rightly so, of the freedom and high syntax score in our cath lab. So we have this routine consultation in those cases, and so that not CTO by itself. I mean, it's rarely a case which was referred to surgeon because of CTO and they came to us. It's less of an issue. But most important is many of the CTOs have a higher syntax score, so that they go routinely for cabbage. Because one CTO of the LED, proximal LED, will give you a syntax score of almost 13.
Some die. You want to try whisper antigrade?
Antigrade. I think it's ready other side. So leave this wire there. Let the kissing wire technique here. Will die now, antigrade, or it has gone into the side branch.
Mm-hmm.
Yeah, it's coming out. So leave it there.
Some die.
Okay, now here, good. It's making a better turn. Even it's a small area of subintimal.
No,
okay.
Some die.
Now go integrate now. Okay. Good. If you can advance further.
See, now this wire has gone into the intima, but negotiating retrograde is a little difficult in the sense, since the tip is stiff. You don't want to be too aggressive.
No, but let's take a good picture now, so that we have to show that we are truly in the true lumen. Give the integrate injection basically.
Come closer.
Yeah.
Don't pull the guide.
Somewhere I think you go a little subintimal, right towards the
only, that's fine. They'll just go into the regular way.
Very interesting to see at what stage you will decide to go antigrade.
No, I would say the steps wise will be that you advance this wire, advance your corsair through the lesion, whether it's a corsair or a small balloon, plus minus dilate with a small balloon, but go across with a corsair, it has created a channel, pull back your corsair and then go antegrade. So now you have established your antegrade lumen, and that is the true lumen associated with the lower issues. So here it looks like that is a small area of subintimal, but the majority of the vessel is, go a little die again. Good. So we are in the true lumen.
But see, now it is not going to make a turn into the, get into the
Which is
guide.
okay. You can leave it there. That's the whole purpose. So we don't need to get too crazy with a lot of people that it has to exteriorize, go inside, although this wire has gone very easily. No, it's not there.
No.
It's outside.
No, yeah.
As long as your corsair goes through, this will be okay. You'll go easy
So
with the antegrade.
the other thing is to get the corsair in, what you can do is, I think you are not in there, right? Sometime you are out in the,
I would say leave that wire now. Just get your corsair across. Just
no,
rotate
corsair
through.
is not going to go. What you have to do is anchor this wire. So what we can go with the regular balloon and dilate something there. It anchors the wire, then corsair will go up. Then we can exteriorize.
Okay. The good. Get a run through wire and get a 2.5 balloon.
2.5 will anchor it. 3.0 unit.
3.0.
Yeah.
Good. 3.0. You can give high pressure. 3.012 is good.
Have you, Samin, revised your approach to patients when now you're telling them what kind of success chances are you giving them before approaching a CTO?
Oh, absolutely. We actually, as a part of our the yearly annual protocol, cath lab handbook, outcome handbooks, we actually have our success rate, which makes that after 2 steps, with the two steps reaching about 90%.
Must be very reassuring to patients.
Yes, absolutely. Actually, matter of fact, I have a patient who just talking about, you said referring for cabbage. Patient was referred to a surgeon for 1 vessel. Patient is a doctor, the son is a doctor at Mount Sinai, but medical student. The patient himself is a doctor and referred to the surgeon for mid-LED CTO. Done outside, could not, and 1 vessel. Everything else is good. Referred for 1 vessel cabbage. They showed me the film yesterday and took my opinion because surgeon said, this case, that Dr. Sharma, our VCath lab should be able to do without any problem. And that patient is coming Friday to have a CTO of the mid-LED recanalized. It's just to say, it's basically to reverse referral from the surgeon because they know the confidence level that those kind of cases we should be able to do routinely.
Look, that is really the complete aim of a heart team.
Yes.
People work in collaborative fashions. Surgeons come to know exactly where we do a better job, and we hold the same healthy respect for them.
That's it. Now, Anu, tell us your steps now.
I did anchor, take it out. Now I was trying to anchor the wire so I can get the corsair.
I think it went up.
It slightly, yeah.
But with the anchor would have gone better. Okay, guide is coming out.
Okay. So what you do is you take the antegrade balloon back into the guide and advance the wire. And pull back your corsair. So, pull that. Good. Yeah, guide is a little
Take
bit
a deep breath.
Yeah, these guides are just a little sucked in. Both the guides. Breathe normally. Good. Pressures are good. These are all sucked in guides. So don't. Therefore, it's also important. We use side holes for the right coronary in these CTOs. Very common. People say, well, there's a lot of contrast, but I can tell you, and I've seen many of these cases live, that clearly using the side holes prevent that spasm, slow flow, and so. So I'm very particular about using a side hole for the right corner.
So what I did was, it's in the lumen, but get out of the ostium, and it's in the aorta. I'm just trying to get the corsair sucked in.
Corsair has gone through now.
I don't know.
Yeah, Corsair has gone through. So let's pull back the Corsair a little bit and we deflate the balloon and try to see wire into the main lumen.
So you still have to
Yeah.
get me a regular fielder now, so we can get into the.
No, but you already have one wire there. Integrate.
I'm talking if we can go through the Corsair and exteriorize that.
Idea is avoid that if you can
Yeah.
go integrate. Yeah, good. So everything looks good. Okay, pull back. I'm deflating. Pull back your Corsair.
No, I don't want to deflate. You mean you have to created a channel? you're
Yeah,
saying?
you have created channel.
Remember, if we were subintimal, did we do that? Little subintimal there.
Yeah, it's okay.
We try to use a.
Yeah. Now this is a very key point, that now that Corsair has created a lumen, but you have to pull back the Corsair if you are trying to integrate. Otherwise it will not go. So you want to follow that channel, or you now have to work quite bit on the proximally to get wire into the guide catheter. But I think you pull back the Corsair. There's nothing wrong in that.
I think there's some amount of subintimal channel there. I think we should just exteriorize it.
Okay, then you have to put a target for the guide.
Yeah, but not with this wire. This wire is not letting me get into the guide.
Okay,
so
which
I'm
one?
trying to do is, if I am sure the Corsair is in the lumen, right? And then I'm going to change to fielder wire and then get
Fielder
in.
exchange length fielder, please.
I can go regular fielder.
But then you have to just go with exchange length.
Take a deep breath, sir. Okay, guys. Hold the guide. It's coming out. Sir, deep breath.
Give me. Take that. Yeah,
Some
excellent.
dye on the RCSS before I take out the. I think we're in the lumen there.
Yep.
No, why that one? Very difficult.
No, right now you're there, so
No,
it will be okay.
Get me regular fielder. Oh, this is the regular fielder. No, it's not fielder. This is miracle.
Get another fielder.
Or we had fielder FC. You can give me that too. You want to use that?
Again, making a short curve so that you can direct the tip.
And important thing is have your wire ready before you take out the wire from the any Corsair, or if you have a fine cross. Because while you're trying to make the curve, and if you have your wire out already,
You'll
could
trap
get into
the
trap.
air and a little bit of thrombus, so that you just have to, and the flush a little bit.
Anu, how much target ACT are you trying with the angiomax?
I mean, we had an ACT of 290, but as soon as I crossed, we
You'll get it in the 350 range.
300 range. Yeah. I mean, until you crossed and you know you're okay, you can have your ACT less than 300, between 280 to 290.
Samin, not only have you emphasized about the importance of the right guides, both for contralateral, but also meticulous attention to watching how it moves back and forth in the
Okay,
left
so
main.
now I got with the floppy wire, I'm into the RCA.
And you can,
No, okay, just give me another 2.5
no, but you have the
balloon.
balloon there. You can stabilize the balloon.
No, we took it out.
You have the balloon there.
Yeah, we just have to stabilize it. Now, get us that wiper wire, please. Okay, let's go.
Okay.
Go up with the guide.
So now we are doing that, anchoring the wire into the guide catheter, our integrate wire.
So now, see
retrograde
that
wire.
once you have anchored it, it's so easy to get the. Now get the wiper. See now, very important, every time, I know the fellow is holding, but the guide is not getting sucked into the left main. That's
Right.
the key. You took this out?
Both wires.
Out. Now what we do is go with the wiper. You have it?
And wiper is, it's a 0.0.
No, it's the same. It's a stainless steel. It's a peripheral wire, but 360. So we are able to exteriorize well. Take it out. Same thing. I'm just injecting little saline, so there's no suction.
Samin, except for a rare patient who may be looking at some non-cardiac surgery, no role for bare metal stents in a CTO.
Absolutely.
Absolutely.
Yeah.
No.
And
If
particularly the CTO, I would say that you, as you mentioned, that non-cardiac surgery, those cases probably should be able to go through surgery and then come back for intervention. Yeah.
Right.
Now this is a wiper is made by CSI. It's a 335 millimeter length.
So now I got,
0.014.
yeah, I got it here. So we keep going down. Go APSs.
Samin, besides the wiper, what are the options available to
Oh, you can
people?
use other wire also. I mean, you can, before the wiper or those who don't have wiper, you can just use the exchange length extra support wire.
So what are the favorable attributes of the wiper wire here?
It's a stainless steel and
the
very
body.
hard body is very good.
strong.
So we have to be very careful that now it has gone through the left main, through the septal, right there, you know, that it does not cause any spasm or at the level of the.
And so
Left
this is the
main
wire
and
which of the 0.12, it will be used for that diamond back elliptical atherectomy. And this is for use in peripherals, but coronary is 0.012 wire. And this is a long exchange length wire which will then come out from your contralateral guide. And you have to put the your needle
I will show you.
introducer once you come there.
So we are coming out there. Give me the needle introducer. So how do you get the wire out? Through the Y connector?
Put the needle introducer there.
So you take your Y connector, disengage that.
Make sure we're showing the hand there, right?
Yes,
Good.
we are. We
Good.
see it very nicely. Excellent job with the camera team there.
Yeah.
Holding it. Somebody has to be advancing.
Yeah.
It's a tough. Keep going. Okay.
Good. You want to see it from the coronary point of view first?
That's okay. Hold it up.
We disconnected a little too early.
Yeah, you are the one pushing it.
Make sure the guides are all good. Yep.
Yeah. Hush.
It has to come out now. Good. Advance a little more.
Okay, good.
Yeah. See that wire has come out now? Now put into your...
And, focus there. And there we see it coming. And they're going to
So this is another point where you go through this wire introducer other way. See there?
yeah.
Come out. So the wire truly has come out without any trouble. Connect it. Take your wire.
220 compliant balloon.
So now we are good to go.
Anu, excellent demonstration, and I hope the viewers are finding these valuable tips, and
Now
hopefully
let's-
they'll be able to use it to great benefit.
See here.
Yeah,
No
excellent
change.
positioning. Yeah, wonderful, stable guiding catheters, both of them.
So now what we can do is take this out. which is the
Corsair.
give me the fine cross. Very important next step is taking the Corsair out. We have to get the fine cross through this wire, anti-grade wire, and we have to get an anti-grade wire across RCA.
Yeah, because
Flush
that's all
the-
being done to get the anti-grade wire across the RCA. Keep this. Now it will be a little floppy is the issue that you need to cut, or how would you get the
No, we
floppy?
can get it. So since Corsair is there, we can quickly go through it. Nothing is going to move.
So you're using the Corsair to provide more stability here at this point?
Yeah, because now this is a 360 wire, but we are going anti-grade.
What
through the
balloon?
RCA.
What balloon have you chosen?
Now that the Corsair has gone, you can take a 2520 balloon to pre-dilate.
Let's go with the 2O. We have the 2O ready. 2O20, and then we go. See, now on that Viper wire, which is retrograde, although the tip is the distal tip, we are going through.
Now see if I'm going to go Cine. Fine cross has reached there, but we don't have the wire out here. Almost reaching it. Advance a little
Keep
bit.
advance.
Little bit, not much. Now what we can do actually is I'm going to start pulling the Corsair back so you can start getting the fine cross ahead, okay? So I'm coming back with now this is another thing here. See, it starts getting sucked in. Pulling back the Corsair out. Getting
And
sucked.
this is a very important step. This where your left guide will suck in, or your donor guide will suck in, whether right or left.
So I'm
So counter. So the
it
keep-
out and
yeah.
taking it out. Now you can advance the fine cross a little bit.
Routine use of side hole catheters is a clear overkill. In fact, you'll just end up giving so much more dye.
Well, only thing is that it causes otherwise
Okay, wait.
spasm.
Yes, oh, good. Now see the wire has come out, right?
Yeah.
Good. So now you
Because
get your
particularly for the right, I'm very much impressed by the spasm the right catheter creates. So that routine only for the right I'm talking about.
This is another important technique that I want to show is how you get normally taking this the stainless steel hardcore Viper wire through the circle that has created could be dangerous in the sense you could slice the artery when you're pulling it out. So you have to be careful. This is the technique that we want to show, which is called the kissing. Now you have your fine cross all the way. See that? I'm going to go Cine.
Yeah.
The kiss between the fine cross as well as the Corsair. And this is the way you keep it, and now you'll be able to take out your Viper without any problem. So I'm taking the Viper out here. Otherwise it's a very complicated technique because the guide gets sucked in. Now when you are at the level of the septal, then you can take everything out. It's come out. Wait, now we can take out
Now you're taking out both the wire as well as the Corsair out.
yeah, take out the wire, everything. Pull. Guide. Yeah, guide. Wire out.
It's absolutely wonderful demonstration, Anu.
Yeah. And wire will be a little difficult.
Should not be. Good.
Yeah.
A very large right coronary artery.
Yeah.
The wire is stuck here.
Huh?
This wire still has not come out.
Now?
Yep.
Yeah. Now what you have to do is engage, make sure your left system is good, and then you can take out the guide wire.
You think the wire was getting caught in a septal?
Yeah,
Yeah, yeah.
spasm. Yeah, this
Spasm,
is
same.
expected.
Right.
So this is where
You just have to that thing you see with the Corsair, you just leave it there, take it out, but then it was still went into the
Let's say if it was stuck for a little, it was a little more
just-
stubborn. What would you have done?
no, just give a
more,
little bit nitro. That's
yeah,
it.
little nitro, verapamil, give a little morphine to the patient, let them relax. That's it.
No, this is 300.
Yeah.
So you want to take a picture of the left side. If you are good, we take out the guide.
Okay.
Always now do you document?
No, don't take out yet.
Why?
Right. No, because we need to see the distal vessel all has been seen. But let's see the left side. That's good.
Good.
Okay. Good. We go to LO view now. Good.
What wire is this?
This is the fielder.
The fielder. Regular fielder, exchange length. That's okay. Let's open this first. And then we'll have chance to. Good.
Pull the cursor too
Have to be
fast.
very, very careful now. Now, other step which I say that the Sharma's modification is that before going this further, once you have done the corsair across, just try one simple wire antigrade. But clearly the limitation is that if you have multiple subintimal channel, it will give you trouble. But if you can go through it, it will cut down your procedure time, right? 2 or 20. Okay, we are 2 or 20.
In this case, we knew that we had a subintimal channel, short subintimal channel, and we had re-entered. I think we should not be taking a chance.
Yeah, that's a very important point. That means every time, the point I wanted to make here is that not every case
You need
have to go with the
exteriorize.
exteriorize. Yes, that's the only point I was trying to
Right.
make, and that many of the cases here we have seen, and even you remember in the symposium,
Right.
the live case we actually could not get, and this the anti-grade wire just went in.
Which was your point number 4 on
Yeah.
the summary list?
Ready?
Absolutely.
Take a picture, anti-grade.
Yeah, the
I
injection.
don't have a picture, anti-grade.
Yeah, we can dilate now. Good.
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 In the meantime, also to inform our viewers, the companion webcast, the peripheral interventions hosted by Dr. Prakash Krishnan. I hope for people wanting tips in some of these procedures, hopefully you'll find it useful.
Lesion in the diet.
You know?
The video of our broadcast today will be posted later this week.
Yeah.
Yeah, very good. So you want to put one long strand?
Yeah.
Huh?
What I want to do is, let's put the patient has a resolute integrity, so they get a 3-0.
Designs, please. Designs.
Samin, any status
ready.
update on your absorb experience here?
Yep, showing working good.
How many cases?
Actually, the very strict criterion. So there is a distal disease also.
Yeah.
Let's try to get a wire into the main vessel and do dilatation. We knew this was we could see actually at the bifurcation earlier.
Think the proximal and ostial area needs something too?
Yeah, exactly. You want to dilate with this?
Where?
Distal.
This is 20 millimeter balloon. It is not that long.
Huh?
It's not that long, the lesion.
No, but we have to cover that lesion completely anyway.
No. Go back, see. You don't have to put those long strands there.
Yeah. Like that, long. No, dilate there. Now, question comes always in the total occlusion. I try to avoid the bifurcation, so select one big vessel. And I would say in this, it was
It's
a
a
PDA was
very
so
large
big.
PDA.
Yeah. So I think in AP cranial, we should try to get a wire into the PDA and we dilate that area. You can put a side-by-side other wire, no problem. Maybe a run through or so will be easier. But let's try, keep this balloon. Because we need to open the ostium. And we are reaching to the time also, so let's just open the ostium.
Get us a regular fielder to get into that, right?
Field or run through? Yeah.
No. Or dilate and stent across?
Yeah.
Then why you want
Okay,
to?
this is the fielder. Now put a wire into the PDA. That's what I'm saying here. In this case, you have to get a wire into the PDA. Both vessels are big, but what you really want,
This fielder FC.
yeah. Clean that balloon again, huh?
Science.
I'm sorry, what?
Reese knows. Science.
Any preference in CTOs for a DES?
No, I think the trials actually the trials which have compared more for the BMS, although there's a trial with the EES comparing with our cipher stents, both were similar. so that there is no true difference.
Stop talking to the patient, give him sedation.
Okay.
Yeah.
You want to go to aleocranial? Yeah. Just few more minutes. Giving you the dye.
This is not a good wire. You know what other thing is also the
No, but is that the PDA? Because
this is the PDA, the large PDA.
yeah,
which
if
we
this is
came
the large
up-
PDA, then we just keep it this way. Then fine. You want to take another
Just-
picture?
Crazy.
Just-
1 second.
Just
Go to
stent
the-
across in.
Yeah.
Yeah. No, but question is, we want to see which one, the vessel where we are now, is this that our large PDA?
I think it is.
Yep.
Let's see in the.
Yeah. See, this
Good.
is the PDA, and this is the small other branch.
I think
Okay.
you're in the
Good.
right
Just
branch.
stand
Good.
across.
Yeah. Ready?
Yeah. Let me take it out.
So you're probably
This is a
looking
long
at
wire.
3 stents, no? Around the PDA, in the mid portion, and possibly in the.
Huh? What did you
Yeah,
want?
where is the run through? Has to resolve it. Huh? We need now the run through. I think side by side, or you have the wire there already.
No, I took it off.
No, you have one wire already.
Yeah, this is a 300 wire.
Okay, therefore let's dilate.
Oh, you want to dilate that?
Yeah.
These stenones after all this work.
Huh?
After all this work. What did you mention? Let him go to CC, okay?
Good.
Because this will not end up with too many long stents. That's why I wanted a shorter there.
Okay, ready?
Yeah, come.
Good. Go up. 6, 8, 10, 12. Good. That was a very tight lesion there.
Okay, down.
Negative. I think you can come back in the guide and then make a stent strategy. Because we don't need to worry about showing entire the vessel. It's just as long as we show the main area for CTO and the distal. Yeah, good.
Nice.
Yeah. So therefore, clearly that you need 2 stents, I would say. The area of one you have to put across. Maybe question is, do you want to put one after the bifurcation and one at the angle and leave the rest of the area for the future?
I would take a 275/28.
Or third, or
No,
30.
275/28 there.
Resolute. Yeah. We need a longer the resolutes integrity. So we had 2.75/28 or 30, and then 30/38. Yeah, but that's for the yeah, good. Yeah. Okay. Now question is, do you want to cut the wire or put a run through side by side?
You can just leave it.
Sameer,
Two stents, right?
question for you, a 2-part question. What is the long-term dual antiplatelet strategy, and how will you follow up this patient?
Yeah, this patient actually had a symptom and infralateral ischemia, as you know, with the guidelines now. Yeah. And then get a 3.0 or 3.5. You want 3 or 3.5?
3.5.
3.5 for 38. Yeah, that I think the anticoagulation we learned that even with the long stents, multiple stents, 1 year is probably good enough, and the patients will be followed clinically, because patient is, even after opening the circ, had a symptoms largely because you can imagine with this mega right coronary artery, and he had an infralateral ischemia on stress. Now the guidelines which actually we really went to, our fellows did a tremendous job to come up that who should have a stress test following revascularization. The guidelines basically are that after the PCI, that you want to go after the bifurcation, or where do you want to go?
Across.
Across? Okay.
Because there's disease before.
Okay, let's take a picture then.
It's too long, see?
No, but you need to go distal.
Okay.
You want to see previous view? Yeah. That what is recommended is that I would say just after the disc and then leave the bifurcation alone for the future. Yeah.
There's also
after the PCI, you're such a
slightly distal to where you are. There is another segment
to cover,
of
the bifurcation assess. There's disease at the
okay, but then I go a little further and we'll put a one proximally.
No,
If
we're
require
good.
one extra.
Okay. Just at the bifurcation,
Right.
it's covering whatever we want. No?
No, it's not covering completely. You need to go a little further. Remember, you have to go PDA coverage. Proximally, we'll put another 2 stent probably.
Going. Some die. It's bad.
Yeah, now it's okay. I
I would
would
take a 38 then.
okay. My preference is why not you just put after the bifurcation. Leave the bifurcation alone for the time being, and we put one into the distal. Take a picture. Yeah, here. Go plus.
There's disease, the tightest disease is at the bifurcation.
No, but that's not the bifurcation. That's what I'm
Yeah,
saying.
this
No,
one,
this is
yeah.
not the bifurcation. Remember, that's a small branch. That area, go plus. No. We are in the different one. Plus. See here? Yeah, good. This is a very good one. So that area with a small branch, and so is the good segment. So I would say put one stent after the EV continuation and that bifurcation in the PDA, and then we put one into the distal RCA. If required additional, we can put in the mid. That way you are fully covered. See, that area was never diseased. The disease was before that small branch. That we need to cover with the 38. Good. Let's go a little distal.
Dilated everything there.
Which is okay. Little balloon is all right. Go further a little bit. Good. Little die now. Again antegrade. You need to go a few millimeters further.
is that 275.
It's a 275 watt? 30. Good.
Too distal.
Too far, no? Too
Too far,
distal there,
yeah.
yeah. Too distal.
See that? I think if you take 38, it'll cover everything.
Okay. We go up here?
Yeah,
Okay.
it's not covered.
All right.
now.
10 atmosphere. Pull the wire a little bit. 12, 14.
Down.
The 2 inflations.
Let us at 3538. This looks so big. I think we'll leave a 3 only.
Yeah.
No, but we have opened 3.5, which is moderate pressure will be okay.
We have opened it.
Yeah. No, but it's a big vessel. I think it will plump up with the nitroglycerin because we saw such a big one. Yeah. Let's open the distal edge of the stent.
No. Okay, take a picture now.
Well,
Looks excellent.
Good.
Nonsense. No, the proximal edge is not covered.
It probably will require 2 more stents. We knew that this case will be a 3 stent case.
Eastern strategy, yeah.
And after that, we can, we go off and end this case. After this, putting 1 more stent and remaining, if required, 3rd we can do later on.
Samin,
Yes.
summarize for us in this wonderful teaching case, what are some of the key points which people need to pay attention in retrograde?
It basically is that very step-by-step complex procedure and use of various devices, particularly Corsair and exchange length Viper in when you need to exteriorize as shown here are important. And the one issue could still be that you can always try to look into the cases that once you have gone through, try the integrated wire once, and if you can advance, will great. If not, then of course you need another wire. Give us the run through side by side. Huh?
Yeah.
Yeah, give us the run through.
Sir, take a deep breath.
Two essential, both philosophical as well as strategic points you have is you try to not get into any re-entry and
Yes.
and you cut to the chase and get the Corsair in quickly.
That's it.
And then you mentioned that once you have achieved this, go ahead, rely on the anti-grade wire and dilate
Yes.
through that.
Yep, absolutely.
So what, it needs a buddy wire to get in the long stent, or
Yeah, or we can use many of those guideliners and Godzilla that integrate support, but it's just not going because it's now the long 38 and it's a 3.5. resolute. So that clearly that we need probably one extra wire antigrade to go through it. Good. So now leave that wire and you still have the other wire there.
So does New York have a CTO club too?
Not any separate by that name, but I'm sure there are few centers.
Giving you ideas.
Yes. Yep, I know there are a lot of them. The Japanese, the Canadian, and CTO club that make it a New York CTO club also. Yeah.
Where do you want it placed?
Yeah, a little further. I think we now have to overlap it. Right, you want to see it?
Some die.
Okay. Now keep your hand to the side.
I will be too big.
You have to go a little further because now we have to overlap.
Take a cine.
Okay.
And you feel comfortable with the overlapped 3-5?
No, it has not
It's too
overlapped.
big.
Yeah,
The
too
3-5
big.
will be
And
too big. This
Yeah, but low pressure, I mean, you don't have to worry about. See, then now you have to go all the way there because that's where the disease was. Now, it always happens these patients when got to quite long. Yeah, now it's too far. I'm going to show, we'll take the other wire out. But clearly when you use the buddy wire, although you can leave it, it's never the issue. Want to take a picture now?
Yeah.
either you come back a little bit or go forward a little bit.
Yeah. I would go a little forward a little
Yeah,
bit because
and
we need
overlap,
one more
yeah.
stent anyway.
Necessary the stenting.
Good, good, that's good. Going up. Okay, low pressure. So just we are going to deploy at 10 atmosphere. Now many times it won't expand, that's okay. So you're going to post dilate with a 3.0 or 3.25. So clearly it's a very big vessel and a very big stent. So it did not expand, that's okay.
Yeah, particularly in that distal area, that was
What
More
post dilatation balloon you need? 3.0, 30?
Whatever.
Huh? Let's pull back a little bit. Good. Let's open the inflow.
Okay.
Take a picture.
Some picture.
just a beautiful,
Just
beautiful
have to
case.
dilate. Yeah, and then we can just put a one more stent and so. So I think we can, if because of the sake of time, we just come back to the last point and we'll ask AK to comment on and summarize. So this basically the take-home message of today's case, the status of the CTO lesion PCI and retrograde recanalization approach. Improvement in the procedural technique and devices has resulted in increasing success of CTO PCI. A successful CTO PCI is associated with better long-term outcome, decreased cost and lower mortality. Second, the technique of retrograde recanalization is gaining increasing momentum and adds to the already increasing technical success rates. Every advanced CTO PCI center should have dedicated experienced operator for the retrograde approach. With that, we take three questions now. Which one of the antegrade lesion morphology is associated with the highest rates of unsuccessful CTO recanalization? Blunt stump, side branch at the site of occlusion, short occlusion length, severe calcification, and bridge collaterals. Knowing that all of them are unfavorable, which one is the highest unfavorable lesion morphology? Second, a successful CTO recanalization is associated with following except lower MACE, lower mortality, lower stent thrombosis, lower incidence of long-term cabbage, and lower angina. And the third question for today is the following are the techniques for retrograde recanalization except kissing wire approach, the retrograde wire cross, the control antegrade and retrograde tracking, reverse which is cart, reverse cart, and the parallel wire technique. With that note, Anu, you can just sum it up now, or you want to put a balloon or stent? What is it now?
We are putting another stand.
Okay, so let's put this third stent, and Now your wire is different wire. Okay. So this after the third, we'll ask, make one comment, and then we are done for this complex case, and still able to do it in our timely fashion of just maybe a few minutes extra.
So this really becomes our first live webcast of the modified CTO kidney technique.
Yes.
Anu, glad that you were able to add to your collection of contributions to interventional cardiology. I think this is extremely beneficial and hopefully cuts down some of the needless steps in a retrograde CTO.
Take a big picture. No. Take a little picture.
Okay, down.
Good. And we can put the same.
You'll probably go and dilate that distal site a little bit more.
We are going to dilate it.
Okay.
There's a lot of disease in this right coronary artery.
Killed this guy. Now we have the post dilation, right?
Yeah. That we can do later, but I think we can come. We show the last picture, and we just sum it up, and then we just do a little post dilatation, which is just a follow-up once we bring it back into the guide. 1 second. Good. Ready? We take the picture. We'll do the last one. Beautiful.
Looks wonderful.
Good. Now you want to just say the point and we'll post dilate. 3030 high pressure. Good.
So I think how can we do retrograde faster? Just to go over the steps is the same. First and foremost is the decision when you want to do retrograde, and the key could be like this case selection. When we knew that with the multiple bridge collaterals, maybe you go retrograde to begin with. Selecting the septal, the teaching is the same. You go to a septal, go with the Corsair, give injection, see how the septal connections are there, change the wire direction and try to wire the septal, which is a cut short, which I have shown here, is that you have seen some septal. In this patient, there was a septal connection. But if there is no septal connection, you still go to your first 3 major septals, go with your best wire, usually the glide coated wire, whether it's Fielder FC, get into that and just try to find a septal that we will connect into the PDA, or vice versa from the PDA into the LAD. So that way you cut down the step. Is a faster technique. Once you've gone through, your next one is just a channel dilator using the Corsair, which I showed. You got to be gentle, just wait, little deep breath, just with the movement of the heartbeat, it will keep going into the vessel. If it does not, that's where you need to dilate the septal and then get your channel dilator. That way we were able to, then the next thing was how to get through the CTO. Since the cap is soft, the Fielder was able to go through it, but same, it was not going into the true lumen, means it was trying to go subintimal. That's when we changed to the CTO wire, which was again a softer. You can go with Miracle 3 or 6. We tried Miracle 6, would not. And one other escalation which got us true into the lumen. And then you get your, since we knew there was subintimal, the short area of subintimal, I did not want to take a chance of taking the Corsair out and go antigrade and dilate it. Instead, we did the exteriorization, which we showed. Once we had the Corsair in the RCA lumen, then your stiff wire is not going to get you into the guide. You need to use the floppy wire, which we went with the Fielder. We were able to get into the guide and change to Viper wire, exteriorize. And other most important technique that we showed was how you take this Viper wire out of the body, the KISS technique, which we saw. The Corsair and the fine cross have to be together. Get your Viper wire out so that your 2 guides are not getting sucked into the vessel. Once that wire is out, then with the fine cross, you get into your PDA with any over the wire antigrade, you balloon dilate like we showed here.
And very important that the advantage of the current second, or you call second to third generation stents, are that keeps all the side branches patent. Look at that. That is small rudimentary PDA, the main and the AV continuation stent across, that still remain very nicely patent. Yeah.
To get us fluoro time and die.
Yeah.
Samin, enormously instructive case. I would only add where Anu kept mentioning a faster modified technique. I think faster but preserves the safety. Exceptional case. Anu, you are checking the fluoro time for us.
We have a dual injection dye of both bottle is both the bottle was how much? 140 dye and
3720.
Yeah, 37 fluoro time.
Yep. All right. So with that note, we conclude this CTO retrograde recanalization approach as we promised, and very successful results.
And we were slow because we have to go step by step teaching the steps.
Yes.
Anu and Samin, exceptional case, wonderful job by your fellows also. We'll see you next time, September 17th for our next presentation.